these are my disclosures. It has been a global consensus that dry eye treatment is very important and had been addressed on a lot of meetings, ESCRS, ASCRS, APACRS. There are always surveys talking about that. And it's actually now common practice to deal with that. We know if we have a dry eye surface that we do a lot of things wrong, and we cannot afford that if we do that with premium lenses, with diffractive technology and so on. IOL calculation may be wrong. The idea of using toric lenses can be completely be destroyed if you have a dry surface and you get funny measurements. Then after surgery, visual acuity will take longer to become good, and also the whole phase of neuroadaptation when you have a trifocal lens can be interrupted or can be interfered if you have a dry eye and you don't have full vision. And these are all things that are not good, and we have to deal with it. It is a science for itself to talk about dry eye and all the influencing factors. Yeah, you have the TFOS management scheme here, as you know, where we know about what are the interventions, what are the possibilities that we have. We know that not only the production of tears and the composition of the tears is important, also eyelid anomalies and other things have to be addressed. And the long-term impact on dry eye, on the surfaces, on the conjunctiva, on the cornea surface, and so on, are very, very big and can really interfere with a lot of other things we're doing. A couple of years ago, we were actually doing a study where we combined the cataract surgery and postoperative treatment with the use of EVO tears, the EVOCAT study. This is a study. This is an eye drop which stabilized the lipid layer, so to say. And we did a randomized study compared standard treatment, which only included steroids and antibiotics, with a combination. And it was fairly clear that those patients who got the additional treatment of this lipid layer saving eye drop got substantial better outcome. You can see here that after 5 weeks, the break-up time increased from 6.8 to 14 seconds. So it has a huge impact and stabilizes the thing. The only problem is patient has to do another eye drop application. So he has a couple of antibiotics, steroids, and then also this. So if he gets more than 5 or 6 eye drops, most of them will not adhere to that and will not do it all the time. So that is an issue. We also looked at it if we just go for hyaluronic acid preparations, such as the Hylocare, as you can see here. Again, there was an improvement, but if you carefully look at the details, for example, the break-up time increased from 6.4 to 7.8 seconds. So the impact was not as big as with the other one, because the lipid layer is the important thing, and the continuity of the tears onto the surface. So if we can manipulate the meibomium glands and get them to produce very well the lipid layer, then we have actually a good outcome. And with the JETT plasma device, we have now a new thing that can do that. And you see here the device is very small. It's like a laptop size, and you have this handpiece there, and you can apply different applicators here. They are made of gold or silver, and it's not only a device for attacking meibomian gland disease. You can do a lot of surface treatments, including also dermal surface treatments. So with the big one here, you actually can do kind of non-invasive facelifting and create very nice skin, or attack neurodermitis and stuff like this. So it's not a thing that you only use for tear treatment, also for a versatile instrument. It is based on direct current implementation here. It kind of creates a precise and electric field. The patient is holding a grounding electrode during the procedure, and you create this potential between these two things, your handpiece and the grounding electrode, and the field directs flow and charged particles in the area where you touch the tissue. So you have some physical and some chemical implementation here that you really can go under the skin or under the first dermal tissues, if you look at the meibomian glands. But you can also, for example, use it for the conjunctiva. We have a lot of patients that have a so-called conjunctiva chalasis. It's a term that it's not really widely accepted or used, but if you sometimes look at the slit lamp of your patients, the conjunctiva is hanging almost on the lid margin, and the tears are dropping down because of these folds that are there. And they have tears running out of the eye, even though they don't see it, what the problem is. And if you look at this, especially when they sit up, you can see that. And you can shrink these chalasis down to a very outlined surface, and then the patient will do much better. And also the conductivity of the tear film is better stabilized with it. So when we look at the machinery, you have a steady electron flow creating that, and this electrochemical interface induces also changes in the pH of the environment, and with that you can have a direct impact on cells, on the membranes of the cells, and also you boost more or less the circularity in terms of the lymph system and the blood system. So cell regeneration, cell stimulation, and also anti-inflammatory effects you can get with that. And all these things we have on a diseased eyelid, when we have blepharitis, when we have dry eye, when we have stuck meibomian glands, all this comes together. So with this platform, we are tackling the meibomian gland challenge, so to say. And the problem with meibomian gland disease is that it really goes in circles down and down and down. The more you have, the more problems you have, the more it changes the surface and increases the pathology of the eye with hyperkeratinization and all kinds of stuff, including chronic inflammation, which they always have. So what you want to attack is the meibomian glands directly, but also reducing the stuff that is hanging between the eyelid rim and the eyelashes, sometimes also with Demodex. It can also kill the Demodex with it, and really heal the epithelium and make this let's say a sound and healthy surface. So with proper management, we can achieve, first of all, perfect diagnostic. We know the astigmatism. We don't have differences between a Pentacam and a IOL master because we have a nice surface and everything is measured the right way. We can exactly calculate a toric lens. We can exactly calculate an intraocular lens, especially, of course, a premium diffractive lens, for example. And then, of course, the patient himself will feel that he has much better comfort, and also goes more comfortable into the surgery because you already have healed and treated a disease which was giving him some discomfort. So if you implement that, that is good. And there are a lot of studies now and also surveys indicating that a lot of surgeons thinking about that or ranking this as a very high priority, and it has been on a lot of tabloids on the topic to talk about this. Let's see a patient here, a cataract patient, a female patient that comes for cataract surgery and has a posterior blepharitis, dry eye, and these kind of things, and eyelid margin irritation and so on. So when we use the dry eye treatment with the JETT plasma, you see it here, we first start here with the conjunctival chalasis, applying several of these points. This is an under-topical anesthesia. I usually give some lidocaine gel or some conjugaine eye drops, first conjugaine, then some lidocaine gel. And as you can see, the patient can react to comments and say, look here, look there. And then I apply this in a punctual fashion. In this way, we straighten out the conjunctiva. Yeah, the conjunctiva then is more or less straight onto the sclera, and we don't have these folds and things that can interfere with tear film conformity. Now we are going to the meibomian glands and applying this, and you see directly the stuff coming out of the meibomian glands. Yeah, you see how they discharge this secret there, secretion there. And we do it from the inner side. It's not very difficult, you just go there. The patient don't have any pain on this. And we do it from the inside, we do it from the outside, including the eyelashes here. Hopefully not damaging the makeup. And then after that we also do the both eyes, of course, and also the upper lid, eyelid, and this so on. So you can see very nicely how what stuff comes out there and how much it gets stimulated now. And I think we're now switching to the upper eyelid, which can also easily be done. Usually people don't really treat the upper eyelid so much, but I think it's worthwhile doing it. When you look at the keratograph 5M, that's the device from Oculus, where you analyze different features of dry eye in the patient, including also in interferometry for the lipid layer. You see here before, the lipid layer was in that area, almost in the red area, and afterwards you see everything is in the green area. You can look at different things. For example, this patient had enough tears. So the tear, what is going on here? The tear meniscus was in the green area here before and after. So it was not a question of having not enough tears, but it was a question of the tear film quality. Here you see the breakup time, and you can see like a land card that here the left eye has a lot of deficiencies and the right eye a little bit, and afterwards everything was much better. And if you look here at the interferometry, we were at 3 here before, almost in the red area, and afterwards we were at 0, so at 1. So it was completely healed, and a very good lipid layer on the eye. And the other things also get a little bit better, like redness and telangiectasia. And the patient after a week had a good visual acuity with the intensity lens, uncorrected distance, intermediate and near acuity of 0.1 or better in all distances. Binocularly it was at 0 logMAR. So the combination of it, the patient screening, then preparing him before surgery already with the first treatment, having sound data directly before you calculate the IOL, and then do a post-op DED management is an ideal combination not to have any trouble with the patient. You already create a positive atmosphere when you heal him from the dry eye. Then you do the surgery and even get better view, and he can appreciate the good view because he is not compromised by the early treatment and the trauma he had. So he has already fresh eyes directly after surgery and can enjoy the vision. So this is a very good combination. Talking about the lens he's receiving, I want to mention our experience with the intensity lens, which is a very specific lens designed to improve light utilization. A standard trifocal lens usually loses 14 to 15% of light. And they were actually able, by going through different iterations and getting a so-called sinusoidal diffractive pattern, to reduce the loss of light by 50 to 60%. This is basically a pentafocal lens that shifts some of the energy to the 3 foci and gives you a very interesting distribution of light. When you have a small pupil and you look in the near, you need most of the light for the near. Most of the other trifocal lenses only have 20-30% of light for the near, for reading. But this lens goes much higher, to 40-50%. when you have a smaller pupil and you look in the near. And then later, when the pupil goes slightly larger, the distance part takes over and gets most part of the light. So this is a very interesting concept, and I would say much better than some of the older lenses that have been on the market, as you can see here, with more or less standard light distribution. And intermediate, in, for example, with Artelisa only gets 15%, which I think nowadays is not enough. When we look at our prospective randomized study, we're just doing one comparing it with the Panoptics. We've implanted 50 lenses in both groups. We see that we have excellent outcome. One versus 3 months, you see here, getting to 0 logma at more or less all distances, as you can see here. Very competitive to the Panoptics Clarion here. After 3 months, it's getting even better if you look at the binocular outcome. So you're in the minus range, and you get an excellent and very flat defocus curve. You see here we are more or less higher than 0.1 logma for 3-4 diopters, and better than 0.2 logma by 4 to 5 diopters. So excellent outcome. But the really secret of the lens is that you have a better light distribution. And if you look at the photopic and mesopic contrast sensitivity, what you can see here is that they are within the normal age range, and that is better than the Panoptics. Definitely significantly better than the Panoptics, which doesn't have that kind of design. And this translates, for example, also in a fact that Intensity IOL, in 46%, half of the patients say they have no halos at all. Yeah, whereas in Panoptics, only 1/4 of the patients says that. You have a little bit of dysphotopsia in terms of slight to no slight glare, but we're talking here about like 15% of patients, similar to Panoptics, that have some glare. 85% have more or less no issue with that. So in conclusion, with the Intensity, we get excellent defocus curve, excellent visual acuity outcome. We have a minimal light loss, and we can actually intensify that by treating the surface preoperatively. Then we also have better target refraction and less deviation from what we were targeting at. And this also increases the neuroadaptation, because the patient sometimes takes 3-6 months and still complaining. So if the eye is fine, if there is no additional issue, they are much faster into it and have much higher level of patient satisfaction. So I think the combination of both is something that we really can offer, and we can charge for it. It's not that they get the treatment for free. Yeah, you can significantly increase also your turnover in terms of reimbursement if you apply that technology. And if the patient got the treatment and they are happy, after a year they may have some other issues, they come back and they let the treatment being done again. So you can continuously work with the JETT plasma device to keep the dry eye disease away from the patient, or if it's just minimal, you just give an update, so to say, every couple of months in order to keep it on a very good level. And this way it's very easy to combine, especially with premium lens patients. They really like the treatment and go for it. So thank you very much for your attention. Any questions? Yeah, please.
I use a gold tip or no?
Yeah, it's working.
Working? Okay. I use a gold tip for the conjunctival crisis. Which different with silver and gold tip?
I wouldn't say there's a huge difference if you use the golden or the silver in these few punctions that you do. Yeah. For me, both is the same. Yeah. But if you work longer on it, and my experience is not so long. Yeah, I'm not that long user. I think you will see some difference. But at the moment, I can say I get along very nicely with a silver applicator. Yeah.
And the tips, slim tips, it's different to use slim tips or the other tips?
Which kind of tip you take depends on several things. If you have a very, very tight eye, like an Asian eye, with it can be different from an elderly, let's say Caucasian eye, which is hanging around like this. And then I take sometimes the different sizes of the tip. Yeah.
Yes. The little size is more effective.
Little size is more focused on specific points. With the larger one, you have a better coverage.